The bad news. Heart disease is the number one killer of both men and women. The good news. There's a lot we can do to lower that risk. Should we change our diet or get a calcium scan of our heart? Let's see where the evidence takes us. Hi, I'm Dr. Bobby Du Bois, and welcome to Live Long and Well, a podcast where we will talk about what you can do to live as long as possible and with as much energy and vigor that you wish. Together, we will explore what practical and evidence-supported steps you can take. Come join me on this very important journey, and I hope that you feel empowered along the way. I'm a physician, Ironman triathlete, and have published several hundred scientific studies. I'm honored to be your guide. Welcome, listeners, to episode number 37. We can reduce our risk of heart disease. Well, heart disease, cardiovascular disease, is the number one killer of men and women. And we've talked in prior episodes about the 6 pillars, which can each help reduce that risk, whether it's exercise, getting good sleep, sauna and cold plunge, nutrition, social relationships, mind-body harmony. We've also talked in another episode about doing screening tests like a total body MRI or large panels of blood studies. And I express my concern that when you do these large number of studies, you might get a false positive, sending you down a path of more tests, potential complications, and really a lot of uncertainty. Today, we're going to dive a bit deeper into cardiovascular disease. And we're going to try to figure out a couple of things. What do we know about what we should eat? What do we think about a calcium heart scan? Are these things that we should consider and talk to our doctor about? Well, I could share my opinion, and of course I probably will, and the evidence that I've run across. But more importantly, we have a guest today, Dr. Anthony Pearson. And I am thrilled to have Dr. Pearson join us today. He's a board-certified cardiologist. He was on faculty at several academic medical centers, published over 100 peer-reviewed papers. And he's also been in private practice for about 20 years. So he has both the academic and the patient care experience. His focus is on preventive medicine, ways to reduce the risk of heart disease. And he has a very broad, holistic view, incorporating diet, lifestyle, exercise, and of course, medications. And most importantly, and why I think he's an ideal person here today, is that he's also an educator, very broadly stated. He's a columnist for MedPage Today, and for the last decade, he has been writing The Skeptical Cardiologist, a blog on its website and now as a Substack. And some of the article titles that I think you'll find of interest: butter, good or bad? Should we take antioxidants? Should we take blood pressure medicines in the morning or at night? How to stave off dementia, walnuts and cognition, and the dangers of unnecessary cardiac procedures. And I will have links to his locations if you would like to read and follow him. I do, and it's been wonderful. So, Dr. Pearson, welcome to Live Long and Well.
Thank you, Bobby. It's my pleasure. I'm a big fan of your podcast, and I'm happy to be here.
Well, wonderful. I know when we chatted a week or so ago, and you were telling me a bit about how did you get into, certainly not necessarily how you got into the cardiology business. That has, of course, its own story. But how did you get into the education and writing approach? And you mentioned something about having croissants and butter with your dear wife. And I thought, what a great place to begin. So maybe tell all of us a little bit about how did that start out?
Sure. For the first 20 years or so of my career, followed the guidelines and the dogma that had been presented to me in the dietary world, and that had started in 1977 with some dietary guidelines to Americans that said we should all be cutting down fat and increasing carbs. And I was following that, and I would battle with my first wife over whether we had skim milk or full fat milk in the refrigerator. I wanted my kids drinking skim milk, and she wanted full fat. We eventually ended up at 2%. But after following these guidelines, which I assumed were solidly based in science, I was drinking skim milk, eating low or non-fat yogurt, and I avoided butter like the plague, and I ate egg white omelets. But I met my second wife, and while she was still what I used to call on my blog the eternal fiancé, we were having a brunch outside at a very nice restaurant in St. Louis, and I found myself lecturing her on her decision to consume a croissant slathered with butter.
And the best way to eat them, of course.
Yes, according to her, and I was just astonished, and she challenged my viewpoint on this, as she felt like she was healthy and thin and could eat croissants slathered with butter. And so when she challenged that, I went on a quest to discover the scientific sources underpinning my recommendations. And I found that in this particular area, they were very lacking. And it kind of led me to become the skeptical cardiologist at that point. A lot of my early writings in 2013 were about the kind of dietary myths that we had all accepted without substantial evidence. And so now I consume full-fat milk, yogurt, and cheese as much as I desire, and my omelets are made from full eggs, including egg yolks. And I think when I first started this journey, I came across a study that was done in Wales, where I was actually born in Wales and came to the United States when I was 5, by Peter Elwood. And he had studied some Welshmen and found that those who consumed the most milk had a 13% lower risk of dying than those who consumed milk, which was a big, went against the grain of the recommendations to consume low-fat milk, because at this time, everybody was consuming high-fat milk. And I communicated with him, and he revealed to me that he had done a meta-analysis of all the studies, which he published in 2010 in the European Journal of Clinical Nutrition. And it also showed that consuming dairy products of all kinds actually lowered cardiometabolic risk and lowered the risk of dying from cardiovascular disease. So that was the beginning of my journey as a skeptical cardiologist.
And have subsequent studies borne out that the saturated fat in dairy is not problematic?
It has. There have been lots of publications in this area. There are lots of meta-analysis. And they have kind of been, some have shown no effect. Most have shown a slight benefit from consuming dairy on cardiometabolic risk factors and on reducing the risk of stroke. And the most recent one was published in 2024, and I can give you a link to that.
That'd be great.
It is in the journal Nutrition, and it confirms that, and and shows that there is really no evidence that low-fat dairy is better for you than full-fat. And the evidence is quite strong that full-fat and fermented dairy products actually lower the risk of cardiometabolic disease measured by things like metabolic syndrome, which includes hypertension, diabetes, and obesity. And so I think that this is more and more, this is being recognized.
Well, this is fascinating and also very reassuring, since I, of course, love to cook with butter and cream and all those wonderful things, and love cheese. So let me probe a little bit. So what you're saying is dairy may not be problematic. Perhaps it is even protective. Now, we know that the full-fat dairy is saturated fat, or has a fair bit of it. Are you saying that saturated fats in general are fine, or there's something peculiar about the dairy saturated fats that make dairy eating safer than having a ribeye steak at 3 meals a day?
Yeah, I think that one of the reasons that full-fat dairy continues to be not recommended in most nutritional guidelines is because of the saturated fat issue. Dairy contributes about a quarter of the saturated fat to the diet of Americans. And the mainstream nutritional guidelines want to promote a simple message that all saturated fats are bad for you, so that the public doesn't get confused. But the actual fact is that dairy fat is much different than the fat that you get from red meat, for example.
And why might that?
Fat that you get from.
Why might that be?
It's much because the saturated fats and the fatty acids in general are a broad family ranging from short chain to medium chain to long chain. And each one of those fatty acids has a slightly different effect. Some of them definitely raise LDL and raise your blood pressure. Some of them don't do that. Some of them might raise the LDL a little bit, but also raise the HDL. And the truth is that we don't consume these fatty acids in and of themselves. They're in a food matrix. And there is quite a bit of evidence that the food matrix that dairy is in is protective and behaves differently when we put it into our bodies than if we were just consuming the fatty acids as in an experiment where we can purify it in some way. So it's a big heterogeneous family of compounds, and it's a mistake to consider them all as equally harmful to you.
Okay, that's helpful. Now, I know we had a brief chance to talk a little bit about the paleo and keto diets, which have gotten a lot of attention. These are folks who feel like they want to cut out carbohydrates from their diet. And when people are eating a lot of fat and protein, because that's really what's left, you get vegetables and fat and protein, some of these folks, the cholesterol levels, specifically the LDL cholesterol, can go way up. Is that a worrisome thing when somebody is trying one of these diets and the LDL goes way high? Do you just say, well, you're losing weight, that's a wonderful thing, so what, the LDL's high? Or do you say, no, we should try to do something about that?
Well, I think it is a worrisome, and it is a situation where we really have to be very careful that we're not predisposing the patient to high risk of building up atherosclerotic plaque and heart attack and stroke as a result of that. And there is a study that was just published within the last month, which has gotten a lot of attention on social media. It is called the Keto-CAD Study, CAD standing for coronary artery disease. And these patients were these lean mass hyper responders, which in the keto world, if you are not obese and if you don't have diabetes, sometimes about maybe 20% of individuals will develop these very high LDL levels and apolipoprotein B, which is the particle that gets the LDL into the lining of the arteries and triggers heart attacks. And the community there believes that they are protected against heart disease, against plaque buildup. And this study was an attempt to look at that plaque buildup over a year in these individuals. And what it showed to me is that, number one, they have already built up a significant amount of plaque. And within a year, that plaque progressed. And plaque, again, is the faster that plaque progresses, the larger the burden of that plaque, the higher the risk those patients are of heart attack and stroke. So there are ways to modify the keto diet to make it less likely to raise the LDL and the ApoB, and that is to use avocado oil, olive oil, and not necessarily consume massive amounts of meat. But the bottom line is, if that diet is giving you an LDL over 180, you are at high risk, and either the diet should be changed or you should be started on medications to get that LDL down.
That's very helpful. Thank you. And I think putting the various types of fats in context, the dairy, the non-dairy, and then sort of the extreme case of the paleo keto where you're getting a tremendous amount of fat. Wonderful. Yeah. Let's switch.
And I would add that I am a keto-friendly cardiologist. When I first started the blog, I went on a keto diet and I researched it, and I think it's been very beneficial for many of my patients in losing substantial amounts of weight. But again, we have to monitor these patients to make sure that they are not harming themselves in the long run.
Well, like everything we do in medicine, whether it's a medication we're giving someone or it's lifestyle changes, there are always going to be risks and benefits. And obviously losing weight is critically important for us to live long and well. And if paleo helps you get there, that's a wonderful thing. And if it doesn't change your LDL level, wonderful. But if it does, then I think you talk to your doctor and maybe you get treated. And then you can have really the best of both worlds of being on a diet that seems effective for you and keeping that risk factor under control. Well, that's great.
Absolutely.
Let's switch gears. And this is a fascinating one. Folks have probably heard about the calcium heart scan. It's something that gets advertised on radio, TV, social media. It's a pretty inexpensive screening test, $100 or so. And as my audience knows, I'm generally not that excited about routine, large screening things. Now, of course, if it's a mammogram or a colonoscopy or a pap smear, these are very important. They're recommended by U.S. Preventive Services Task Force, and the benefits have been shown to outweigh the harms. But when you just do 100 or 200 blood tests, or you do a total body MRI, just looking for early forms of disease, I think you can end up with some difficulties and false positives. And anybody who's interested in listening more about it, by all means, go to my prior episode. But when we chatted about the calcium heart scans, you had a very important way to think through it. So maybe first tell folks, what are these calcium heart scans and why might it be helpful for folks?
Sure. The calcium scan, coronary artery calcium scan is what we generally call it, an abbreviated CAC, is a kind of X-ray or CT scan. It is non-invasive in that there are no needles, there are no catheters placed into your artery, and it is done using a CAT scan or CT scan. And it is our best way of determining whether there is any plaque in your coronary arteries and how much you have compared to other people your age. It is not covered by insurance, but in most of the places where I've worked, I've been able to get it for around $100 paid out of the pocket. And it is a very safe and very, very accurate test to measure the amount of calcium in your coronary arteries. Calcium builds up. Plaque starts developing very early in our lives, possibly even in childhood. And that atherosclerotic plaque, over time, as it heals and progresses, calcium is deposited into it. And when we look with this CT scan, we're looking to determine how much calcium you have compared to normals your age. The risk of this test is that you are getting a small amount of radiation. It's usually measured in millisieverts. It's about 1 millisievert on average, which compares to about 0.4 for a mammogram, so it's about twice as much as a mammogram. And each year, if you're in the Midwest, you get about 3 millisieverts of radiation from background sources. So it's not considered to be high or dangerous in terms of increasing risk of cancer. And so I think it's a great tool to assess in an individual fashion, to kind of personalize the patient that's in front of me, how much plaque they've built up, and as a result of that plaque, what is their risk of heart attack and stroke down the line.
So as we've talked about in our last call, I tried to play devil's advocate a little bit. It's like, okay, so we know if their blood pressure is elevated, we should do something about it. We know if their cholesterol is elevated, they should try to do something about it if they have diabetes or they're overweight. So how would this add to the equation? And really, are you suggesting that pretty much everybody in their 50s or so get one of these things? Is it going to change what you do by getting these results? Obviously, they could be negative or they could be positive. And if they're negative, you can be very happy about that. If it's positive, but you're already treating their blood pressure and their cholesterol and their weight and such, how will this help us?
Yeah, I think this is a common question, and is one of the reasons that it's not being universally applied, although I would say that any preventive cardiologist that I've talked to or listened to is an advocate of using these in a lot of people. And that is because progress against sudden cardiac arrest, death from atherosclerotic cardiovascular disease has slowed down in the last 20 years. And that's the problem with atherosclerotic disease, with coronary artery disease, heart disease. The initial symptom is often not chest pain or angina that occurs with exertion due to a tightly blocked artery. The initial symptom can just be a heart attack coming out of the blue and then resulting in an abnormal rhythm that drops you dead and causes cardiac arrest. So we don't always get warnings. And the plaque can build up to very dangerously high levels without having any symptoms, without knowing that anything is going on. So what the calcium does, what coronary calcium does, is give us an idea of how much plaque is built up and what is your true risk. Now, what the current way that primary care physicians are told to assess this is by kind of estimating the risk in an individual in front of them based on the standard risk factors such as blood pressure, diabetes, cigarette smoking, and the lipid levels, the cholesterol levels. But these are not these so-called pooled cohort equations that estimate risk are not applicable to young adults and older adults. They come from studies decades ago. They overestimate the risk in the general population. And 1 out of every 3 persons who present with a heart attack would have been considered low to moderate risk. They would not have been treated. So these are kind of not adequate if we want to be very proactive, if we want to be very aggressive about reducing this risk of heart attack and sudden death. I would also point out that there are no trials supporting the use of these pooled cohort equations. So basically what they do is kind of try to estimate your 10-year risk of heart attack and stroke. Low risk is considered less than 5%, high risk greater than 20%. But there's a large number of people that are in the borderline risk or the intermediate risk. And that is the population that most benefits from getting their risk better personalized.
Now, many people have heard a story like this. My brother-in-law had a heart attack and died, and so I decided to get the cardiac calcium scan. And thank God I did, because it showed a high number, and then they showed that my blood vessels were, very narrowed. I got an angioplasty, and I think I'm now cured, or at least I'm in so much better of a place. And I think what we need to tell our listeners is that the purpose of the calcium scan is not a plumbing diagram. You're not inevitably going to get a positive test and say, oh, you need bypass surgery or you need those vessels opened. That, in fact, the studies don't support that for people who are in a stable, asymptomatic condition, but rather that these people just need medications or lifestyle changes. So maybe sort of walk the listeners from a positive study to, does that inevitably mean surgery?
Yeah, it's a great point, Bobby, and one that needs to be emphasized, and it's a hard point to get across to patients, in that we can identify that you're at high risk with a calcium score. You can have a very high score for your age that indicates that you have a lot of plaque buildup. But if you are free of symptoms, if you are not having a heart attack, a stent is not going to lower that risk at all, and neither will a bypass operation. If you're free of symptoms and you're active and you have built up a lot of plaque, what you need is very aggressive lifestyle and drug therapy to lower that risk. You don't need a stent, and therefore you don't necessarily need to have more testing at this point. And in fact, the majority of patients that I see with high calcium scores, we are just treating to get their cholesterol levels to goal and to address all their other risk factors and kind of optimize the therapy for them, short of having to put a device in like a stent. And the problem is that some cardiologists feel that this is an indication for downstream testing with, say, a stress test. And stress tests are problematic because they have a lot of false positives. And even if they're normal, they don't necessarily mean that you're not at super high risk. And the best study, I think, in this area, I think you and I discussed the COURAGE study, but the best study in this area came out about 5 years ago. It's called the ischemia trial, ISCHEMIA. And it took patients who had evidence for significantly blocked arteries and who had abnormal stress tests showing that there was poor blood flow to their heart muscle, which is called ischemia, and randomized them to either getting an invasive approach with a catheterization and possible stenting versus just managing them with lifestyle and drug therapy. And there was no difference in outcomes. And this was an amazing study that helped us understand that we can treat patients just with medications. We don't have to rush to doing these procedures, and the stent that person's friend got didn't necessarily save their lives.
That's an important study, an important set of findings. Well, I think we're going to bring this discussion to a close. Always when we talk about medical issues, we need to remind you, talk to your doctor. But now I think you're armed with some questions to ask about your diet and whether dairy is fine for you, and a consideration of the calcium scan and whether that might be beneficial to help fine-tune what you do. Dr. Pearson, thank you. Thank you for being on the podcast. Thank you for allowing me to continue to love my butter and my cream, and for helping listeners understand the calcium scans and where they may fit in for them. And I look forward to having your wisdom join us on future episodes. So thank you so much.
You bet, Bobby. It's my pleasure.
Well, let's just close by saying I want everyone to live long and well and have a happy heart. If you are able to go to the link in the show notes and go to a brief couple of questions to give me feedback on my podcast, that would be helpful. And I'm, as always, interested in topics that everyone might want to hear about. Well, with that, I look forward to future dialogues. Thanks so much for listening to Live Long and Well with Dr. Bobby. If you like this episode, please provide a review on Apple or Spotify or wherever you listen. If you want to continue this journey or want to receive my newsletter on practical and scientific ways to improve your health and longevity, please visit me at drbobbylivellongandwell.com. That's doctor as in DR, Bobby, livelongandwell.com.